Hello and welcome back. I'm Rahul Gosain, here as always with my brother and co-host Rohit Gosain on the Oncology Brothers podcast. As general hematologists and oncologists, a good portion of our practice involves non-malignant hematology. And yet another common referral, be it in outpatient or inpatient settings for us, ends up being thrombocytopenia. In today's challenging cases episode, we're jumping into real life scenarios around thrombocytopenia management, including ITP. What about anticoagulation with low platelets? And then end off with HIT being one of the differentials. To walk us through, we're excited to have one of the co hosts for the Fellows on Call podcast and now a hematologist at the University of Pennsylvania, Dr. Ronak Mistry. Ronak, thanks for joining us today.
Thank you, guys. Thanks for having me. I've listened to you guys for a while now. We've obviously met at a lot of conferences, so it's exciting to finally get to join you on your show.
Thanks so much for joining us, Ronak. We got quite a bit to cover in this thrombocytopenia world. We'll start off with our first case, where we have a 29-year-old woman with recent upper respiratory infection. And during the course, she has been having worsening fatigue, and she has noticed some petechiae in her arms and legs. With lab work, which was concerning for a platelet count of 9,000 and a strong family history of autoimmune disorder. Even though we are thinking about ITP, though, this is still diagnosis of exclusion. Can you walk us through your initial workup and treatment options?
Absolutely. This is not unfamiliar to those of us that see patients like this in the hospital. With a platelet count of 9,000, ITP is certainly on the differential. There are very few reasons why patients can have severe thrombocytopenia with platelet counts that low. But as you also alluded to, ITP is still a diagnosis of exclusion. What do you mean by that? In situations of thrombocytopenia is ruling out things like DIC, which is really important. Obviously, ruling out things like TTP and things of that sort. So really your first step here is to request a peripheral smear. Looking at a smear is going to quickly rule out the possibility of schistocytes being visible. That's going to take off a lot of those very scary diagnoses off the differential, at least move them lower down on your list of possibilities. The other thing you're ruling out is pseudothrombocytopenia, right? So there are a subset of patients that can develop thrombocytopenia just from the EDTA that's in the tube. And you're looking for platelet clumping on that smear to really confirm that this is the case. And so, as sort of the next step, I often, if you have the luxury of doing so, you also want to ensure that that platelet count is new. Do you have previous data where they had normal platelets? And so is this 9,000 really far from the patient's baseline, or is this sort of where they live? That also changes the approach you have. In these situations, especially when we see patients in the hospital, a patient presenting to the office with a new complaint. But in situations where they're in the ER or very complex patients, ruling out things like infections, medications, toxins that could impact thrombocytopenia. I often tell my patients platelets are very temperamental. They react to other things that are happening systemically. So being a good internist and taking a good history is really, really important. If you take that off the table and you're feeling good that this is not a DIC-like picture and isn't related to anything else, for instance, antibiotics, then you are going to invoke this diagnosis of ITP. ITP is an immune-mediated process, as many of us know. The biggest component of initial treatment is to decrease that immune response. Steroids are the backbone of our therapy. Sometimes people also add IVIG to this as well. And this is based on some literature to suggest that the use of IVIG is going to help, sort of expedite that platelet response. Typically, we see responses with steroids alone in a few days, but especially in situations where patients have severe ITP and severe thrombocytopenia, such as this patient's count, you want to try to get that count up faster. And so IVIG may be indicated in a situation like this.
Absolutely. Ronak, thanks for walking us through that. Keeping that broad differential, but then quickly coming back to the idea of this being ITP so that you can jump on the treatment. You touched on steroids. What about that high dose DEX, which is 40 milligrams for 4 days, and then you stop versus prednisone? Is there any role of splenectomy now that we have TPO agonists?
These are great questions. I think depending on where people train, dexamethasone is really going to be the first thing that you're reaching for. If you look at the ASH ITP treatment guidelines in general, they're recommending that steroids be limited to less than 6 weeks because of the long-term effects that steroids have systemically. Of course, again, they are the initial mechanism that we use to treat ITP, but we just want to be judicious about their utility, right? Typically, treating patients with dexamethasone 40 milligrams for 4 days. I mentioned IVIG, you can add that in. That's 1 mg per kg for 2 days. Some people do it one by one, some do it all together. It depends on your practice pattern. There are a select group of patients that don't tolerate dexamethasone and tolerate prednisone better. This is also important for patients who are pregnant, where you can't use dexamethasone and prednisone is your agent of choice. In that case, 1 milligram per kilogram is recommended with a taper you can come up with based on how the patient is clinically doing. You asked a great question about other agents. There's going to be a subset of patients that don't respond to initial steroids or IVIG. And that's when we start thinking about the role of second line agents. As you displayed on this slide, there's a slew of options in 2025 based on the ASH ITP guidelines. Your next steps are going to be either rituximab, TPO receptor agonists, and technically splenectomy is still listed. Your question about reaching for splenectomy, in general, we want to wait at least 12 months after ITP is diagnosed before taking somebody to splenectomy. That is because there is going to be a subset of patients that may have a spontaneous resolution of their ITP. And also splenectomy, although a very effective modality for treating ITP, comes with its own side effects, right? There's an increased risk of infection when you take someone's spleen out. There is some complications, morbidity, mortality associated with the splenectomy, including a higher risk of thrombosis in the post-op setting. It's not a benign thing that you want to reach for. Looking at the guidelines, they actually recommend TPO receptor agonists over rituximab now. I think the important question at this juncture is what the patient's preferences are. Do they want something they need to continue taking somewhat indefinitely, which would be your TPO-RA, or are they somebody that just wants to take something, get it over with, in which case 4 weeks of rituximab and they're done for the foreseeable future? That is how we think about some of those next steps. And of course, there's more nuances.
Ronak, treatment certainly is corticosteroids and IVIG. If the patient did respond to this treatment and have similar situation in about 6 months down the road, now developing petechiae and thrombocytopenia, are you going to resort back to steroids and IVIG or move on to the second line options?
I think it depends on the degree of thrombocytopenia. If they're having symptoms, especially petechiae, their platelets are probably pretty low, in which case it's okay to retreat with steroids. But that's going to be that time where your spidey senses need to go up and you have to start asking, I don't think steroids are sufficient here. This is the time to start thinking about whether or not it's appropriate to add a second line agent. Often in these situations, I'll start talking about them and possibly even starting them with the patient while they're still on their steroid course. That way you're bridging onto this new therapy. Because again, the steroids onset of effect is usually several days within a week or so. For TPO receptor agonists, we typically see onset of action within 1 to 2 weeks. Rituxan can take anywhere from 1 to 6 weeks. So you just want something that quickly is going to bring their numbers up. And you have the luxury of knowing that it worked before. That's also something not to overlook.
And any role of platelet transfusion, especially as a reflex response when a patient goes to the emergency department, 9,000 or 8,000 platelet counts, any role of platelet transfusion?
This comes up all the time. We typically recommend against it because in these situations, there are antibodies actively destroying the platelets. So everything you're putting into the patient is getting used up. As we know, blood products are a scarce resource, so we don't like to use them necessarily. And of course, there's also complications with giving people blood products. Not our first line. What we find that is remarkable, and I know our fellows get surprised by this all the time, is sometimes we have patients that are sitting on the floors with the counts of 3, 4, 5, and they have no evidence of bleeding at all. Speaks to just how resilient our platelets are and how effective they are even at low quantities. And so in the absence of bleeding, like true mucosal bleeding, severe hemorrhage, we don't typically reflexively give these patients platelets. We have to patiently wait for their numbers to improve with appropriate therapy.
I think one big take-home message here is not everyone needs that platelet transfusion unless there's bleeding. Even with those low numbers, these platelets are very functional. All right, now let's shift gears to the second case where we have a middle-aged gentleman with hypertension, hyperlipidemia, and cirrhosis from underlying alcohol use. Ronak here We're seeing this patient for a new onset of left leg swelling, and the ultrasound shows acute DVT. 2 months ago, he had an EGD for his underlying cirrhosis, which showed small grade 1 non-bleeding varices. And on labs, his platelets are stable, but low 45,000. Hemoglobin is at 11.5. He otherwise has normal renal function. Ronak, this comes up a lot as well. How do we manage anticoagulation in someone with low platelets?
Absolutely. This is a great question. And there is not a lot of data in this situation. A lot of this is going to be very patient dependent. Truly mean that in this case. In this situation, you mentioned this patient has a chronic thrombocytopenia, which is important. The patient, even at a platelet count of 45,000, doesn't have any evidence of bleeding. They do have this new DVT. The important things to consider here are, in this case, they're small non-bleeding varices. These are part of the equation going into what we're thinking about as hematologists about the risk of anticoagulation and the bleeding complications that can be from anticoagulation versus the benefit of preventing a DVT from propagating and becoming a PE. The other thing to consider here is the location of the DVT. Patients with cirrhosis are hypercoagulable. A common mistake people make, especially when they see elevated INRs, is they assume the patient's protected from DVTs. That's actually not true. These patients can have bleeding and clotting, which is a very challenging situation to be in. And I think the location of the DVT matters. So if it's somebody that has an asymptomatic, in this case, it's not the case, but an asymptomatic, more distal calf DVT, and they're a high risk for bleeding, especially if they have these varices, maybe you want to think twice before reflexively putting them on anticoagulation, or even like an upper extremity DVT, because the risk of propagation in these cases is about 5% or so. And so, definitely lower risk, as opposed to somebody that has a more proximal DVT, where we're talking about numbers closer to 40 to 50% risk of PE progression. And so here you want to think twice, or rather you want to think more actively about starting people on anticoagulation. If you look at some of the guidelines that the American College of Gastroenterology says about 50,000 is the cutoff. This person is right below that cutoff. Some may feel uneasy starting anticoagulation, but I would argue that if this patient has non-bleeding vessels that have recently been evaluated on EGD, they're otherwise very stable from a cirrhosis standpoint, I think it's worth considering therapeutic anticoagulation. Between 30 and 50 is that zone where we don't really know if patients are prone to bleeding. But I would argue that it may be beneficial of at least trialing, prophylactic dose anticoagulation if they tolerate it well after a few weeks, considering moving them up the treatment dose and watching closely. I think agent of choice is important here because we don't know about how they're going to do being on anticoagulation. You want something that's easily reversible. Personally, with normal renal function, I would recommend enoxaparin. It's easy to adjust dosing, easy onset of action both on and off in the event the patient develops bleeding, and it's relatively well tolerated. That's how I would approach the situation.
Certainly, low molecular weight heparin is what I'll resort to as well. Ronak, with regards to whether you are going to add TPO mimetic at all, any role of that while the patient is on anticoagulation?
It's a great question. I have never done so. There are some people that have considered it. I think there's some literature to suggest a theoretical increased risk of thrombosis using a TPO-RA in these situations. I just get a little bit nervous, but I'm sure there's people out there that have considered. I really think about TPO receptor agonists and cirrhosis outside of a DVT setting to try to optimize patients for surgery. I'm not sure I completely buy the idea of getting somebody to an arbitrary threshold just to then be putting them on an agent, right? In my mind, if they're at least benefiting from prophylactic anticoagulation, then I don't see the need to add an additional agent that also comes with its own risk of side effects.
All right, moving along to our third case here, Ronak. We have a 59-year-old gentleman in ICU with a concern of pneumonia and bacteremia. His LFTs and kidney functions are deranged as well. On CBC, we see hemoglobin down to 8.4, mildly elevated LDH at 300. But importantly, platelet counts have downtrended, starting out with baseline of 260K and now currently at 25K. He has been on prophylactic anticoagulation with heparin for DVT. Ronak, with triad of sepsis, falling platelets, AKI, and recent heparin. How do you stepwise work up this possible HIT versus DIC versus even TTP atypical HUS.
This also comes up quite often, especially when we're on consults.
They-
This is certainly a challenging situation, right? This highlights why it's important to have a broad differential when approaching these patients. It sounds like as the patient deteriorated, his platelet count has continued to fall, which supports the notion that part of the patient's clinical picture and the concern for sepsis is probably contributing. Considering TTP is always a good thing to keep in the back of our minds, especially with the presence of these schistocytes, with some of the renal impairment as well. Remember that in TTP, it's typically going to be mild renal impairment, not as severe as HUS. So those are also other things to consider. Just what is the degree of some of these changes? And there's also the possibility of HIT. HIT typically doesn't have schistocytes that are present. It's going to be that low platelet count. I don't think it's ever wrong to at least think about HIT in the differential for acutely ill patients that have been in the hospital. In this case, it's been at least 6 days since the patient's been in the hospital. They've had exposure to heparin. It's important to keep HIT on the differential diagnosis. Calculate that 4T score, right?
Yeah.
Essentially thinking about, the onset of the drop, the amount of the drop in platelets, any evidence of thrombosis, and other contributing factors that can contribute to the patient developing HIT, or rather thrombocytopenia. If that score is low, then you can feel pretty good about the fact that HIT is less likely. If the score is intermediate, which is typically a score of 4 to 5 or 6 to 8 for high, those are going to be situations where you want to at least send off that initial HIT ELISA testing, start these patients on alternative anticoagulation, and allow the testing to come back before you take it off the differential. It is also not wrong if the clinical picture is worrisome enough that you want to consider TTP in the differential, and that's where that plasmic score can be really helpful. So all these prediction tools are useful with the appropriate clinical picture. That's typically how we think through patients in the acute setting, using these tools, using these guidelines, using the clinical scenario to help figure out what the appropriate testing to send off is and what the treatment and management would be.
Ronak, I want to echo a few things. Though HIT is not very common, but if it's being suspected, stopping that offending agent, heparin in this case. Ronak, if HIT is what you're leaning towards in a case like this, what anticoagulation agents do you prefer? In these settings, we have few to choose from.
So if HIT is your suspected diagnosis, and this is based on an intermediate or high 4T score, while your ELISA is in process, it's important to do this alternative anticoagulation. HIT is one of the most prothrombogenic disorders known to mankind, quite frankly, and there's still ongoing inflammation due to platelet activation, even after the heparin is stopped. It is insufficient just to stop the heparin and hope that everything is going to be okay. The agents that we typically use, especially in situations where somebody's acutely ill, are going to be argatroban or bivalirudin. And this is based on the patient's renal function and liver function. It'll depend on the patient. But we like these agents because they work. A lot of our intensivists have a lot of experience with these. They're titratable, just like we titrate heparin. And also in the event that the patient develops significant bleeding, they have a quick onset and a quick offset, which is important to consider in these situations. In more stable patients, use of things like fondaparinux after at least 5 days of parenteral anticoagulation is appropriate. That's one thing to consider. And that's just based on the package insert that you have to have at least 5 days of parenteral anticoagulation before fonda. DOACs are fine in patients with HIT. Typically, these are more stable patients, especially those that have better platelet counts than 25,000. There's no cutoff. A lot of would switch typically once platelets got to 150,000, which is where we feel comfortable about the patient being out of that danger zone. So, the things that you want to avoid obviously are any heparin products. That includes low molecular weight heparin as well. Warfarin in the acute setting is not a good idea. Actually, that can further promote prothrombotic states. And so that is not something that you want to give these patients acutely. Once they're out of the woods, that can be an option moving forward.
Ronak, thanks for touching on all that. So now before we close, a few rapid fire questions and everyday dilemmas that we see. Let's start off with platelet transfusion threshold. This was actually a discussion in my clinic. Should there be a different threshold for patients that have fever? Some guidelines recommend a higher threshold of 20,000 rather than 10,000. which is what we use otherwise in a non-bleeding patient who's not febrile. Your thoughts here?
It's a good question. I think there's not a ton of data on this, but the clinical picture matters. In some of these cases, patients that have fevers and are acutely ill, no matter how many platelet transfusions you give them, their numbers are not really moving. It begs the question of, is 20,000 somewhat arbitrary? Are we shooting for something that isn't realistic? If the patient is not having any clinical evidence of bleeding, maintaining them over 10,000 is perfectly appropriate. If they're starting to show signs of petechiae, mucosal bleeding, other signs of GI bleeding, certainly reaching for that higher threshold is important.
And with regards to the TPO agonists, any role of utilizing them in chemo-induced thrombocytopenia?
That is part of the NCCN supportive care guidelines. There's limited data in this as well, and I believe the best data comes for romiplastum in this situation. So really, I think in these situations, the question that needs to be answered is, what are the risks and benefits of starting this patient on an agent like this? If this is curative therapy and the patient's otherwise fit and doing well, there may be a role to consider this, understanding again and explaining to the patient that the data are maybe not super robust, especially in more palliative settings. Perhaps it does beg the question of whether this is the most appropriate thing. But like I said, in the NCCN, romiplastum is recommended, or rather, one of the agents that can be considered. There are limited data, though, on some of the other agents.
And then I promised, last question from my side, a list of common medications we should keep on our radar that can cause profound thrombocytopenia or platelet dysfunction. Any top offenders to routinely ask for?
Antibiotics are major culprits, cephalosporins, vancomycin. A lot of the anti-epileptics are also ones to consider, especially patients starting on Keppra. I always ask about over-the-counter agents and herbal supplements that people are buying online. Most of those are not approved by the FDA, and we don't know what's necessarily in them. So when in doubt, just tell patients to stop. I had an attending that I learned this from about avoiding things like melatonin, turmeric, of course, NSAIDs and things like this. All of these can increase the risk of bleeding and maybe be contributing to thrombocytopenia, so things you want to avoid. And of course, always remember SSRIs, especially in patients who are thrombocytopenic. Those can really increase patients' risk of bleeding while they're in the patient system.
Awesome, Ronak. Thank you so much for taking the time to walk us through these practical cases that we tend to see in outpatient as well as inpatient settings. For our listeners, let us go a quick recap from today's discussion.
Today, with Dr. Ronak Mistry, a hematologist from the University of Pennsylvania, we tackled some common but challenging thrombocytopenia scenarios, starting with ITP after infection, thrombocytopenia with DVT, and wrapping up with inpatient workup for HIT versus DIC or TTP.
We covered approaches to workup and then escalation of frontline therapies in ITP, which still remains a diagnosis of exclusion. Splenectomy is hardly utilized now in these particular cases. For HIT, stopping offending agent, which is heparin here, in the case while you continue to wait for your workup is extremely important. We hope you enjoyed this series of challenging cases for non-malignant hematology. Make sure to check out our other discussions around FDA approvals, conference highlights, and talks checks. We are the Oncology Brothers.